Hello and welcome to today's webinar on promoting health equity through primary care innovation in Medicaid managed care, made possible by the Commonwealth Fund. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a moderated question and answer session following today's presentations. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and the slides and recording will be shared publicly on chcs.org. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I will now turn the webinar over to Shilpa Patel, Associate Director at the Center for Healthcare Strategies.
Thanks, Travis. Hi, everybody. My name is Shilpa Patel. I'm the Associate Director for Health Equity at the Center for Healthcare Strategies, or CHCS. It is my privilege to welcome you all to our webinar on promoting health equity through primary care innovation in Medicaid managed care. Before we move into the webinar, I just wanted to give a quick overview of our organization. Started in 1995, CHCS's mission is to support innovations in care delivery and improve the health of low-income Americans, particularly individuals with complex and high-cost needs. To achieve its mission, CHCS works with states, health plans, providers, community-based organizations, and federal policymakers on three priorities in particular: integrating services for people with complex needs, advancing delivery system and payment reform, and building Medicaid and cross-sector leadership capacity. Next slide, please. For some additional context, this webinar is on promoting health equity through primary care innovation in Medicaid managed care. Again, not an easy title, but something that we're very excited about. It's part of our learning series, Strengthening Primary Care in Medicaid Managed Care, funded by the Commonwealth Fund. This webinar is focused on health equity, but is part of a larger series on tools and levers that states can use to advance comprehensive primary care strategies that include webinars and resources such as blogs and modules and toolkits. To learn more about the series, please feel free to check out our website listed here, and we'll be shared with the slides after the webinar. Next slide, please. So as part of kind of the roadmap of the series within this project, we previously have shared some information and a webinar on enhancing team-based care in primary care. And today we'll focus on promoting health equity, and forthcoming topics in the series include identifying and addressing social needs, integrating behavioral health care, and using technology to improve access. As part of all of these events, we'll be focusing on how we can intentionally and explicitly advance equity using all of these kind of different topic areas. And a key part of this whole series are the elements included on the bottom here, which include promoting accountability, moving to value-based payment, and monitoring primary care spending and investment. Next slide, please. Okay, so now that I've provided some context in the webinar, I'm excited to dig into the details of today's webinar. So today, as part of our discussion, we'll explore how state health equity goals can be advanced by Medicaid-led efforts that promote equity through their managed care programs, as well as at the provider level through initiatives that are supported by broader delivery system and payment reforms. As part of all of these conversations, we will also hear how Medicaid managed care, primary care providers, and the communities we all serve can work together to promote health equity and racial justice. Next slide, please. In terms of agenda, I'll first start by sharing some details of a complementary module to accompany today's webinar. We will then hear from Michigan's Medicaid Director and representatives from the Southern Jamaica Plain Health Center, a community health center in Boston, Massachusetts, on both of their efforts in this area. We'll then end with a moderated Q&A that will be facilitated by my colleague, Diana Crumley. Next slide, please. And next slide, thank you. So in terms of our speakers, I'm very excited that we are joined today by Dr. Lori Zeffrin, the Vice President of Health System Equity at the Commonwealth Fund, Kate Massey, the Senior Deputy Director for the Medical Services Administration with the Michigan Department of Health and Human Services. In this role, she serves as Michigan's Medicaid Director. Thomas Kiefer is the Executive Director of the Southern Jamaica Plain Health Center, where he works with Dr. Juan Jaime de Zegontita, the center's medical director. And then again, we are joined by my colleague, Diana Kremley, Senior Program Officer at CHCS, who will facilitate the Q&A. Next slide, please. So before we start, I wanted to first turn it over to our colleague, Dr. Lori Zeffran, for some opening comments.
Thank you, Shilpa. Next slide, please. I'm really looking forward to today's presentations. We all know that the clear evidence around the importance of high quality primary health care and that it's associated with improved health outcomes, decreased health disparities, and reduced healthcare costs. And as we think of how primary health care should be designed, there are key attributes that are required to address fragmentation. If we go to the next slides, and really integrating primary health care to ensuring that there are multidisciplinary provider teams, integration of digital health tools, the integration between physical health, behavioral health, and health-related social needs, as well as community engagement, which is a key part of this. Today's conversation, we're going to hear from others around how they're integrating health equity into their primary healthcare work. And if we go to the next slide, we know that primary healthcare is a key piece of the puzzle as we think about advancing health equity. And it's also important and critical to think about access and, from a coverage standpoint, really intentionally address and work towards eliminating systemic racism and promoting health equity in payment models as well. And this is a really important time where all of this work is happening more broadly in our broader healthcare ecosystem in healthcare. And at the Commonwealth Fund, if you go to the next slide, Commonwealth Fund, we recently launched our Advancing Health Equity program. And our goal is really to think through and promote our work and support work that eliminates unequal treatment, unequal experience, unequal outcomes in health and healthcare for people of color by reducing systemic racism in healthcare delivery systems, in healthcare policy and practice, and also in promoting work that changes culture, beliefs, and attitudes. And ultimately, we've had a number of conversations with healthcare delivery systems and healthcare policymakers to help frame our work and agenda and really think how we can intentionally impact healthcare and really promote anti-racism in healthcare as well. Just some areas I'd like to highlight. If you go to the next slide, we think about strategies for delivery system change and really promoting anti-racism in healthcare delivery system. We have a good understanding that unequal treatment and unequal experience and unequal outcomes exist within healthcare delivery systems, and hospitals and health system policies and decisions can really perpetuate or mitigate structural racism, right? And really being intentional about how to mitigate structural racism in the four walls of a hospital system and their surrounding communities is really important. And whether that's, actively investing in and engaging with community partners, improving training of professionals and staff, diversifying the healthcare workforce from the leadership levels on down, to promoting economic and educational opportunities and affordable healthcare for their workforce. Data is actually a key aspect of this, and really leveraging data to advance health equity is also important, because it's really important to understand where you are, where your outcomes are, and to be able to determine if the interventions that are being developed are actually promoting change and really addressing the inequities that exist. It's also critical to really think about from the policy perspective, if you go to the next slide, how policies that help shape payment as well as shape delivery system models as well. And so some of our work will also focusing on analyzing policies for health equity impact. One of the reasons why we're so excited about supporting this work in partnership with Center for Healthcare Strategies is to really think about how to promote health equity via managed care, and what are opportunities in this work by promoting health equity in managed care that can be done through primary health care as well. And as many of you know, having disaggregated data on outcomes, experience, and quality is important, as well as ensuring incentives and promoting equity and value-based care arrangements. So there's definitely a lot of work to be done, and really, really looking forward to this continued partnership. If you go to the next slide, as we think about what should change, the importance of using policy and programmatic levers, promoting systemic change in anti-racism and healthcare policy and payment, as well as centering community-based solutions, and really remembering that there needs to be partnership with people and communities and community-based organizations that are on the ground doing this work today. And through this, there is an opportunity for state and federal legislators to enact policies that address systemic inequities, so that states and communities can have resources to implement changes, as well as the opportunities to spread and scale promising, proven, equity-centered models. So I'm really looking forward to these conversations today, to really hear about the work that's happening on the ground around primary care innovation and managed care and promoting health equity, and really looking forward to this toolkit that's just released, so that can continue to help advance health equity, particularly in primary care, and using Medicaid managed care as a lever to do that. So thanks for having me. Thank you all for participating in this conversation, and looking forward to continued partnership. Next slide.
Thanks so much, Lori. Appreciate your comments. So before we hear from our other speakers, I wanted to first give an overview of some of the content included in that module toolkit that Lori had referenced in her comments as well. Next slide, please. So the module for today is part of a broader toolkit designed to help states use their managed care purchasing authority to advance innovations in primary care. The toolkit outlines strategies to support states in defining primary care priorities and advancing core functions, as well as achieving primary care innovation goals through managed care contractual levers. It also includes design considerations for advanced primary care initiatives, and includes a lot of examples from states and other systems and managed care contract language. Next slide, please. So to ground our conversation, we thought it would be helpful to first start with the definition of health equity. And in our module, we define health equity as the absence of unfair, avoidable, or remediable differences in health among social groups that can be understood as both a process and an outcome. It is a process of sharing power among people to invest and distribute resources to those with greatest need, with the goal of creating just opportunities that result in the ultimate outcome of the elimination of health disparities. We see Medicaid as uniquely situated to advance health equity, both in terms of who is covered under the program, but also in its ability to leverage some existing programs and initiatives, such as those related to member engagement, addressing social needs, to be more intentionally structured to advance equity and reduce disparities for communities experiencing them. Next slide, please. Further, as Lori had mentioned too, we see primary care as another opportunity to promote health equity, given how and what kind of care it provides to patients and communities, but also given some of the disparities and inequities that various communities experience in primary care. Again, I think the primary care lens that this work has is really important and impactful in terms of reducing disparities and advancing equity for the communities who are experiencing inequities. Next slide, please. So we see this module as almost this Venn diagram of bringing it all together, given the opportunities and challenges that primary care, Medicaid managed care, and general health equity efforts offer. This module sits at that intersection in how all of these stakeholders can really come together using the various levers and strategies available to them to more intentionally and explicitly advance equity for the communities that they are all serving. I'll note that the module that I keep referencing and as part of this project is primarily focused on advancing equity for communities of color, but it also acknowledges the importance of achieving health equity for other marginalized communities, as well as the intersectionality of systems of oppression such as ableism and sexism that affect health and well-being. Next slide, please. So similar to other toolkit modules in this series, the module that is specific to promoting health equity offers design considerations for the state, and their stakeholders, again, stakeholders being Medicaid managed care organizations, primary care providers, and the communities that they are all serving, to explore together as part of their aligned goal to reduce disparities and promote equity for their communities. And includes some of the ones that Lori had talked about, from data and kind of making sure that your goals are defined, but also very intentionally offer some of the levers available within the space, including VBP, and making sure that MCOs are being held accountable towards progress towards goals. Next slide, please. And with that, I'm actually happy to turn it over to our colleague, Kate Massey, for her presentation.
Good afternoon, everyone. So I could not have asked for a better setup from Lori and Shilpa, because some of the things that I want to talk to you about this afternoon regarding Michigan's experience really does think about what program levers we have, how we're promoting payment models and community-based solutions. So the actions that Lori was talking about are things that are actually in flight in Michigan, things that we hope to really establish a baseline of performance and activity on and build upon. So Travis, do you mind flipping to the next slide? What I'd like to do this afternoon is focus on kind of three major categories or kind of prongs of our strategy. One is establishing a data baseline. So Shilpa was just talking about data. I want to share with you the Michigan Health Equity Report. This is an investment in resources that we find particularly helpful in Michigan and feeds directly into our strategy. So we'll spend a little bit of time talking about that. I also want to focus on how we've structured our managed care contract and how that has really evolved as a key tool for us. We'll spend a fair amount of time talking about our quality withhold, as well as how we structure value-based payment performance expectations in the managed care contract. But there's another element that I just wanted to kind of touch on at the jump, which is how we are leveraging community health workers, because in our mind, there is a great tie-in between social determinants of health as a way to create an environment of heightened health equity. In our managed care contract, starting last year, actually, it was effective during the pandemic, we imposed a ratio of community health workers to beneficiaries. So for every 5,000 Medicaid beneficiaries that a health plan provides services to, they must have one community health worker. And we provide kind of special dispensation for health plans that are working with community-based community health workers. The reason why this is important to us is because we want to really kind of build a culture and also build a cachet of resources within our managed care program to address social determinants of health. So we are in the process of kind of taking that resource and kind of leveraging it even further so that it aligns more with the state's strategic priorities. But it is a resource that we now have that has been particularly helpful to us during the pandemic and in thinking about pandemic recovery. And then the third thing we're going to talk about, because we're kind of tying all of these various pieces together, managed care, health equity, and primary care, I'll talk about some actual real life examples of how health plans have leveraged value-based purchasing in our program. Next slide. So let's start with baseline setting. In Michigan, we have what we refer to as our Medicaid Health Equity Report. This was actually started by an investment of endowment resources. So this first kicked off with an investment by Michigan's Health Endowment Fund. We look at HEDIS measures and then break them down by race and ethnicity. And what's particularly important is that this report and this level of engagement has been going on for multiple years. So we actually have a longitudinal assessment of how these measures have transformed over time. And it does show that we have opportunities for improvement. So let's get into some of the specific HEDIS measures. Next slide. One of the things that I kind of look at when I see these measures is that we always need to kind of go one level deeper to really understand where there are opportunities to focus ourselves as a Medicaid agency, as well as our partners, whether those be community-based organizations, providers, or health plans. So if we look at, for example, postpartum care and that HEDIS measure, which is in the upper left-hand corner, we'll see that our performance for providing access to African Americans is falling short. So I think that oftentimes when we look at HEDIS measures and we look at disaggregating it, it may be that we expect to see kind of everyone at sort of the same performance level with like one or two kind of disparate racial or ethnic groups, and then kind of trying to solve for those issues. But looking at the data can actually kind of take us in some slightly different directions. So if you look at the HEDIS measure for chlamydia screening, this is one of those instances where even higher levels of utilization can surface a health disparity. And so what you'll see in the results for our chlamydia screening is that African-American women in that instance have higher rates of screening than the rest of our population. And so what we can kind of discern from those data are that we've got some provider biases that are resulting in higher rates of utilization that are problematic that we need to address. We go on to the next slide. Sometimes we'll also think that because we are overachieving relative to national benchmarks, that it may be an opportunity to rest on our laurels, so to speak. And that is not the case at all, because we can still see health disparities there, even when we're above national averages. So in the lead screening example, which is in the upper left-hand corner, you'll see that Michigan is performing relatively well in lead screening. A lot of this is driven, unfortunately, by our Flint crisis. But even though we are achieving above the national norm, we still have health disparities that we need to address, right? We see Hispanic populations kind of leading the charge when it comes to some of our access and utilization, and we should want everyone to get to that higher level. And then the last example is that sometimes it's interesting to see, even when we have decreasing performance, that the health disparities across populations still maintain even when we're not doing the best. So you will see that in adult access to preventive care in the bottom right-hand corner. And unfortunately, we still see pretty decent sized discrepancies between our white beneficiaries as well as our African American beneficiaries. So next slide. So now I want to spend a little bit of time talking about our managed care program, how we've structured it, and kind of tie some of these things together. When it comes to our managed care contract, similar to what we have done as a state, which is to say kind of setting data benchmarks and baselines, we ask the same thing of our health plans. So in our contract, we talk about what the expectations are for health plans to perform data analytics. And we're specific about the types of data that should feed into their enhanced understanding of the people who they serve. So it can be things like claims data, but it can also be other things related to how a health plan operates, like utilization management data. So we ask that health plans draw from the various elements of how they perform their work and make sure that all of that is kind of assessed and aggregated at the health plan level so that it can directly inform their strategy. And they are required to report at least annually to the Medicaid agency what the results are. So we are asking for a direct tie-in between the data analytics that they perform and how that ties directly to evidence-based clinical interventions, as well as community-based partnerships. So what I'm going to talk about in a minute is the primary care partnerships that we've engaged in. A lot of that will focus on value-based purchasing, but there are actually other things that we've done with the data that either we, the state, have collected or that health plans have collected. I had mentioned at the outset that we really leverage our quality withhold as one of the tools. One of the things that we have done is make sure that part of the quality withhold dollars that the health plans are working towards earning back is related to a regionally defined quality metric. And that has been informed by the health equity report that I was just reviewing. So we understand that there are health disparities related to our low birth weight HEDIS measure. And we want to make sure that we're addressing that opportunity as a community, not as discrete individual health plans or the state in the rare case that we have fee-for-service beneficiaries. So we set collective targets, and we ask for health plans to work in partnership with one another to kind of lift the rising tide lifts all boats. That's the expectation that we set. We also ask health plans to partner with community-based organizations, and in certain cases, those can be primary care providers, to make sure that they are addressing social determinants of health. So an example would be that one health plan worked with a provider group to promote centering pregnancy, which is group prenatal care that allows for more autonomous self-direction of care. There have been other health plans that have worked with community-based partners to eliminate asthma-based triggers, but we really want to make sure that the specifics of the health plan population really translate into how they structure the community-based partnerships. And then last is what we're talking about on this particular slide, which is how does the health plan data analytics kind of feed into value-based purchasing? So what's listed here are 3 examples of how our health plans have worked with provider communities, specifically primary care, on tying in VBP along with health disparities. So the first example is actually, and this follows the national standard for VBP. So if you're familiar with that, example 1 is really tying to 2C, which is pay for performance incentive payments. So in example number 1, the health plan provides some upfront resource funding to the provider group to focus on SDOH, and then ties incentive programs to various quality measures. The important caveat here is that some of those quality measures are specifically tied to health disparities. And that's the tie-in that we've been really trying to reinforce within Michigan. In the second example, the health plan is working with federally qualified health centers, or FQHCs. They have a withhold that they apply to all of the PCP claims generated during a 12-month period. And then they tie their withhold payments, the tie back, to quality performance, again, including 1 to 2 specific health disparity measures. And so that example number 2 actually ties to 3B, which is shared savings with downside risk. And then the third example is our withhold example. In that instance, the health plan is already paying the provider a PMPM capitated payment, but they take a portion of the capitated payment, again, tying it to quality measures, specifically 1 to 2 health disparities related quality measures. And then if the provider achieves over 50% of the national average for that HEDIS measure, including the health disparities measure, they earn back all of the dollars. If they don't make that metric, then they unfortunately lose that financial opportunity. So these are some examples where health disparities are specifically tied in. They're connected not only to our managed care program, but also to how our health plans are engaging our primary care partners, and thought it would be helpful for this conversation, and also hopefully helpful to kind of set up our next speaker. So Shilpa, I'll turn it back to you.
Thanks so much, Kate. I was just reflecting, that was so helpful, so many details and really great examples for us to all learn from. So I will now turn it over to our colleagues from the Southern Jamaica Plain Health Center.
All right, thank you. So bringing it down a little, we're a community health center associated with the Brigham Women's Hospital, and we're going to talk primarily about our process and strategy for doing our equity work. So the goals for today are to review our racial justice principles and definitions that guide us, a little bit of the history of the work that we've done, a specific example regarding our adaptive leaders program, and then thoughts about how this would apply to an ACO. So we always begin our work by emphasizing the need for shared definitions. We can't do this work unless we all agree on what we're talking about. Many of the terms that we use in this kind of field of work are used interchangeably, but have actually different meanings rather. This is just sort of a group of categories of terms we emphasize. Normally our presentations sort of begin with a level setting so people understand what we're talking about. But issues of identity, of how these identities result in outcomes, the mechanisms by which the inequities are manifest, and then concepts of how they manifest. It's very important, and I think many people in this audience are aware of the need of the understanding of internalized, meaning beliefs people kind of accept as real in themselves, and personal, which is the interactions of individuals, institutional, which are the rules and policies of a individual organization, and then how all of these things manifest themselves structurally in the world we live in and the resources that are allocated. It's huge to identify the fact that our history impacts our present. So this is just a quick review of our history of the United States and the African American experience. For almost the entirety of the time here, African Americans have been either enslaved or victims of the Jim Crow segregationist policies, and then the war on mass incarceration. We add the significant events in our own institution's history, like the foundation of Harvard in 1636 and our sort of founding hospitals, MGH, the Brigham Women's Hospital, to sort of identify that it's natural then to expect that the policies and procedures and the of our institutions created in this white supremacist historical frame contain them integrated in, and how they need to be identified and addressed. We talked a lot, in our previous speakers talked about the importance of community community engagement. One of the things is knowing your community, and this quick example is the rate of ER visits based on race, and you can see that ours African American is higher than the rest. That is just a difference, and we don't understand how exactly this is being caused. This is a map of Boston, which has different colors in the map. If I told you these, the yellow and the red represent areas of African American Latinx people, I'd be right. If I tell you that's the area of the city that has industrial sites and factories, I'd be right. If I told you that's where the housing issues are, stock is decaying, I'd be right. On and on and on. But what actually this map is from in the 1938, and it's the redlining map, which decided which areas of the city got investment and which did not. So the key point here is that we are living the consequences of our history, and if we don't understand it, then we are not going to be able to understand the reasons for the disparities and how to address them. I'll pass it over to Tom.
Okay, hi everybody, glad to be here with you. You can see my animation kicking in here, but I want to spend about 5 minutes just talk to you about our journey as a small organization, a small community health center. That's part of an academic medical center. We're about a mile away. And what we've been doing for the last 15 years and thinking about being a racial justice organization. So let me just get my notes here. So this work began for us in about 2006 when we started using some showings of the PBS documentary Unnatural Causes, which is a series of about 6 episodes that showed to the public how much of our health is determined by social determinants, by the impacts of racism and other factors like tied to our zip code. So we used that to get our leadership engaged, get our board engaged, and think about how we're going to do this work. And one of the realities that came out in that series is that 80% of an individual's health status and lifetime health status is not determined by their health care, but by where they live and social factors. So we started to raise the question, like if it's only 15 or 20% of a person's lifetime health is determined by healthcare, then what's our role as a community health center to address the other 80%? We got a small grant, and pulled together a cross-sector partnership in our neighborhood of Boston. The Jamaica Plains, about 35,000 people. So we brought together the housing people, the education, the schools, the employment people, to try to look at what's the impact of housing, food safety, and other social determinants on the health of our young people. So what we found out was that there's a very different impact of these social determinants on our young people. Each one of these social determinants, like housing, is dramatically impacted by racism, both the historical racism, like the redlining that Jaime referred to, and current structures, and that the health future of our kids, our white youth and youth of color in our community, was dramatically different unless the inequities that we see are addressed. So we started working with young people. We started a project called Racial Reconciliation, where we bring together white youth and youth of color, juniors and seniors in high school, and we keep them for a whole school year, and we teach them up about epidemiology, public health frameworks, but also about racism, the impacts of racism on health. And this project is now in its 13th year, and it's had a really dramatic impact on the health of the young people involved. And we've learned a huge amount from it too. During that year in 2008, when we did a racism and health presentation for our community partners, and then we ended up morphing that 2-hour presentation into an open monthly training for community members, for doctors, health profession students, and others. And in the past 13 years, we've had about 5,000 people go through that training to better understand how racism impacts health. But also important was looking at our own organization and what does it mean to bring this work home and talk about how we work together. We've trained all of our staff, and we train all of our new staff in looking at racism and health and racial justice. We've developed a staff compact that addressed equity. We have an internal health equity committee that takes on projects to try to incorporate racial justice into everything that we do. And at the same time, we started doing consultation and training to other organizations from a small group of our staff that's really been doing this work for a long time. So they work with organizations locally, statewide, and some national organizations also. In 2015, we started a new effort. So we had many physicians coming to our trainings over the years, and they would often say, "That's great, I really love your approach, but what do I do different as a physician? I spend most of my day in the exam room with patients." So we brought together a small group, like about 12 physicians that are really committed to racial justice, to answer that question. So like, what do they do different in the exam room with patients, and how to really bring the racial justice work, down to earth and into people's work. So that project called Liberation in the Exam Room, and if I have time in a minute, I'm going to show you some of the results of that. But just to finish on our journey, in 2016, we started dramatically increasing the work we do inside of our own hospital and health system. So IHI, Institute for Healthcare Improvement, published a white paper in 2016 called Achieving Health Equity. And they invited 8 organizations around the country who were already doing health equity work to be part of that, including us. Through our participating in that effort, we were really able to move heavily into our hospital, into our Department of Medicine, into our whole health system, to showcase what we had developed and to push the whole organization to focus on health equity and racial justice. So that for the last 5 years, that's been a major effort for us also. So that's a little bit of our journey. Let's see if I can move us forward here. Thank you. So just a little bit about our approach. So these are some of our assumptions. I don't really have time to go through all of this, but the definition we use of racism, we're always talking about racism as a system. That racism is structural in our country. It's in the groundwater is another idea that we use. We lead with racism explicitly. We're not shy about using the word, and it's easier to talk about racism explicitly without getting people bent out of shape if you first make it clear that you're not talking about individual racists, but you're talking about systems. But we never talk about racism exclusively. We include many of these other issues that impact people's lives, sexism and so forth. This can't just be an academic exercise, it's both head and heart work. That's something we've learned a lot from our young people, and it's something we try to incorporate in what we do. We won't solve this if it's merely a diversity project. So As Rinku Sen says, it's not enough just to mix it up, you gotta fix it up. We are really focused on having white people and people of color each having roles to play. For me as a white person, I'm focused a lot on addressing racism with other white people. And then we say, please don't personalize the critique of systems. And now turn around, please do make it personal, because this is something that those of us involved in it really care about it on a personal level too. So I just wanted to spend a minute showing you what our Liberation in the Exam Room project came out with. This is the cover of the document, which we can get you if you want it. But the answer was really 5 different things, what to do differently in the exam room. First of all, understand yourself, your own racial identity, your own privilege or lack of privilege. Spend some time figuring that stuff out. Secondly, understand your community and what are the resources in the community. What's the history of our zip code, and why are things the way they are in our community? And third, more broadly, a knowledge of history. We really encourage our staff and people to invest their time in learning about the history of racism in the US, its impact on all these things. And I am losing that one. And a couple more quick things that on our team, like how is there dynamics on our team? How are we working together with our docs, our medical assistants and nurses? And then finally, in the exam room, to really understand, take time to get to know the patient's identity and experience and build an alliance with them. These are some of the questions we use that our docs use in the exam rooms that really try to get a conversation going, and by building an alliance with the patients, even if it's a cross-racial group, say a white doc and a black patient, to be able to have these conversations and open up the conversation at a more real level with doctor and patient in the room. So another project that came out of this is called Adaptive Leaders, and Jaime's going to speak about that one.
Yeah, so I don't have much time, but essentially Adaptive Leaders is the next level. It's taking not just the principles but rather training people how to respond to them. So it's trainings, lab work, and coaching. People find after the program that they have a better understanding of not just the principles, but how to deal with them, how to address them and offer antidotes. It was used in various circumstances. I just want to finish with this quick discussion on an example. So we had seen about 10 or 12 years ago that there was a disparity at the time, as it was called, between African American and white patients when they arrived at the hospital on their outcomes of heart failure. So this data was presented and went nowhere then. So this time around, we were able to get some work done around it. Essentially, this is a summary that what we find is regardless of your heart failure conditions, the measures of heart failure, there was a difference between Black and white patients in their readmission rates. But the difference wasn't the level of illness, was their identity. So if you're a white, male, well-off person who lived in the suburbs with private insurance, you did the best. If you're a Black, female, urban, publicly insured woman, you did the worst. So the response to that generated some concern, but the difference in this approach was not to just go and find the ER and tell them they're being racist, but to look for an example of how actually the structural factors were contributing. So it involved the residents who were trained in the program engaging with the department getting buy-in, and then creating a process where we began to work with the departments, including the Department of Medicine and the emergency room, to look for things that what was actually driving this. For example, things like if you're a white male from the suburbs, you might already have a cardiologist, so they might already put you in the cardiology department, and that seemed very logical, but in fact was perpetuating existing inequities. So I guess we'll finish up with this, but the story is that it has to be a transformation. The head of our, the chair of our department is an example. So he began by saying the data isn't strong enough. It's just a correlation. And to the point to realize that inequity is real, and that racism is the cause. the what-ism. So rather than say, well, it's the women who do worse, what about sexism? And we always reply, yes, it's an intersectional manifestation. White women do better than Black women, but ultimately there is the oppression of misogyny and racism come together in this case. The structural racism, the actual term, was looked at as a difficult thing to talk about, but we came around to convincing him that this is actually the correct term in this circumstance. And then we actually messaged in the hospital, and ultimately this was published. So that is our thought on the difference in approach, rather than manifesting our programming into a result.
So we're really out of time, but just to summarize, thinking about ACOs, and as I say in this slide here, we don't have a lot of experience planning ACO structures and programming. We're at the other end of the system. We have 85 employees at the health center compared to 80,000 employees in our parent organization, Mass General Brigham. So that's where a lot of the planning happens. But a couple of the tools that we specifically use, we use a critical race theory approach in thinking about how to approach policies, how to think about how our institution works. You can use a different name for it if you want these days, but it really does recognize that the system is infused with racism throughout its history. And if you learn a little bit more about this critical race theory approach, I think it does really help to think about structures. The other tool that we use and encourage people to use is a racial equity impact assessment. You can find this on the these kind of tools on the Race Forward website, but it's a really useful and flexible tool that helps us think through problems when we need to think about a policy or change. Who's going to be impacted? How can we make sure that there's an equitable impact on everybody? So I think I am going to leave it there. And when you get the slides, if you want the slides, our information is on here, plus some of the things that we referenced in our presentation. Thank you.
Thank you so much for that. Great presentations. And with that, we're going to start the question and answer. And Travis, if you can move the slide over, I think there is a little bit of a picture about how to do that. There's a Q&A at the bottom of your screen. You can submit questions. I know we have some great ones already. And I want to start off where a lot of folks first start when they approach the topic of health equity, and that's with data. We have a question about how that data is collected, and if there are issues with patients, members, enrollees self-reporting race, and how you address those obstacles.
Sure. So Diana, do you mind if I kick off? Okay, I think the question started with, do you think that there is a problem? And in Michigan, I can confirm that we know that there's a problem. And the way that we know this is because we are actually partnering with our tribes in Michigan on enhanced reimbursement for services provided to American Indians, Native Americans. And when the tribes actually look at their list of who qualifies as a tribal member versus the list that the Medicaid agency is maintaining, there's a discrepancy. So we have developed a kind of fix for that, but I think it's kind of raised this bigger issue, which is how are people self-reporting when they are seeking Medicaid eligibility. I will say one of the things that we have done within our organization, and this started slightly before the pandemic, is we actually launched a department-wide campaign, which we call the HOPE campaign. And it's an internal employee engagement campaign, but it's getting at how we engage people who are receiving services in the state of Michigan. And the H in HOPE stands for human dignity. So that's really, I think, kind of one of the ways that we've started to more softly and then more directly address DEI related issues. And the notion is that when individuals come into our local offices to apply for Medicaid, our county workers, our health workers should really be engaging and kind of like teasing out this information in a safe space. So that's kind of, not, I guess, pun intended, the hope of kind of how this will be kind of transforming the field. But in addition, I think that as we are kind of getting to a post-pandemic world and we look at how redeterminations are really kind of starting to filter through, there will be additional conversations and opportunities to think about how beneficiaries might be given another opportunity to reevaluate how they are reporting race and ethnicity. And so, we have those opportunities obviously through our state extenders, but we also have health navigators who help with re-enrollment, redetermination, and the like. So I think that we'll hopefully be able to address the issue from that angle as well.
If I could just add, I know for Mass General Brigham, yeah, the race data is a problem, and there's a major effort now going on to fix the problem. I just encourage people, if you're developing the scripts for your registrars or whoever's getting the race data, it really pays to put a lot of effort into just developing these scripts and training your staff to do it, so that the patients really understand why we're asking these questions, and it's not just off-putting to patients that we're asking them these questions, but that they can buy in. And we use like role plays to develop our script to, play it out, see how that feels, and try to build a system where we can really get accurate information from our patients and get them to be engaged in it.
I would add this, and it's a very serious structural problem in our data collection, which is that the categories we are using are not how people identify. We're stuck with the federal sort of races as defined as, for example, in our health center, we have people who identify as other when it comes to race. When we sort of look deeper into that, it turns out that of the people who put other, they also check Hispanic. And that the people who check Hispanic also had put Black, white, other, all the other things. So the real principle is we want to know people's identity. And so we should be asking them what's important to you? How do you identify? And somehow be able to translate that into something useful. And that involves people understanding that the only reason that race is important, unfortunately, is because racism is important. And there's no biological difference. There's nothing wrong with the race that you have, but the society treats us differently. And in order for us to solve the problem, we can't fix what we can't measure.
Those were great responses, and it's so useful to have both, considerations at the state Medicaid agency level and really at that primary care level. So I appreciate you bringing both of those levels to light and seeing, things that can be done and really what's most important in centering the patient during care. We have another question in the chat, and this is something that certainly reinforces our goal in developing the toolkit and having technical assistance initiatives centered on what states can do specifically. And so there's someone in the audience that is working on the next phase of contracts and incorporating anti-racism and health equity into requirements. What's one thing they should bring back and try to incorporate into policy development? And I figure I can turn it to you, Kate.
Yeah, so I think the one thing that we've been talking about throughout this afternoon's conversation is the importance of data so that you can really identify where the opportunities are. So I think that whether it's the state pulling together that data or requiring that of vendors and partners and collaborators, I think that that's one thing. And then I think the other thing that I would say is thinking about how the managed care contract can really complement your Medicaid agency or HHS department strategic plan, because a lot of our strategic plan related to DEI related issues, related to promoting social determinants of health, related to making sure that we're good stewards of the taxpayer dollar through continuing to push on efficiencies. All of those priorities you can see start to filter through the Medicaid managed care contract, whether it's through value-based purchasing, our CHWs and SDOH work, community collaborations, whatever it is. And so I would just kind of think about what the right kind of strategic priorities are for your community and thinking about how you can specifically integrate that into a managed care construct.
I agree completely. I guess what I'd say, based on our experience, if possible, in the policies that you enact, you dedicate some time and effort in the sort of training and framing of the work. I think it's so crucial in a country such as ours, where there's such divisions of understanding of what is actually happening in the country, that we take the time to sort of clearly say why we're doing the work we're doing, what are the factors we think that are involved, what's the framework. I think you would address a problem very differently if all you had to do was to explain to people why they were wrong about racism, versus understanding that our entire system has been created at a time where the priorities of the white male patriarchy were what decided the priorities. And the rest of us who are now sort of trying to make the system work for us there's nothing we can do to overcome that. So the systemic approach, the framework of history, those are the things that we think will the goals are key, but how to get people to believe in them and actually succeed, I think might be improved with that.
Well, thank you so much for your time today. I think we're about at time. And so I, first of all, want to thank our great presenters, Kate Massey, State Medicaid Director at Michigan, and also Tom and Jaime at the Southern Jamaica Plain Health Center. It's been so useful to really think about what levers are available both at the state Medicaid agency level, as well as at the primary care level and the health center level, to really advance this work forward. And perhaps with that, we can tie everything up. We will be posting slides on our website at chcs.org. You can download the Toolkit module that we discussed earlier on in the presentation, as well as the slides and the recording from this presentation. And as always, feel free to chime in with some questions, subscribe to our email, and follow us on social media. But thank you so much for your participation today, and good luck.